On behalf, we'd like to first thank the organizers, and on behalf of Oxygen, who is the sponsor of this session, we'd like to welcome you to a discussion of new technologies in IVF. I'm pleased to be able to introduce this panel. I have actually been working in the IVF lab for the better part of my career. I was responsible for the world's first test tube triplets who turned 30 this summer, so I've been at it for a while. I guess that's why they took me out of mothballs to come on in here and do this introduction and begin this discussion about new technologies in the IVF lab. At this point, I'd like to introduce Fran Meadows, who will act as the moderator of this session. And once again, on behalf of the sponsor, Oxygen, we'd like to thank you.
I might. Thank you. Welcome today, and thank you again for Fertility Planet for streaming online. And we're here in person with a great panel, and we're here to discuss eggs to embryo, new techniques in the IVF lab. And it's great because as an infertility patient myself, I think education and knowing what's going on in the IVF lab and what's going on behind the scenes is very important. So this panel presentation, it's an opportunity to learn more and ask questions about what occurs behind the scenes in the embryology laboratory, from the latest advances in preparing egg and sperm for IVF to the many new and exciting techniques available for embryo selection. It will help you understand the value and the pros and cons of these techniques and technologies as you consider your course of therapy. And going through IVF myself, for a little intro who I am, I'm an author of the book, The Truth Behind the Secret Infertility, and my book came about by going through my struggles of infertility, keeping it silent. And I wrote journals, and I composed it into a book, knowing that there's many other men and women going through infertility that could actually gain some hope from my story, from going through the good, bad, and the ugly, because infertility is not always the happy ending that some people always, I guess, envision. And I struggled with infertility for over 6 years, unexplained infertility, so there was really no underlying medical causes for my condition, but my husband and I, we were not able to conceive. And after struggling for so long, I went through several cycles of IUI, IVF. I did a frozen embryo transfer, which I did become pregnant. Although I did have a late pregnancy loss through that pregnancy. So going through infertility and getting to the point of being pregnant, it's very devastating to then lose a child, but I was able to, come back and say, I was able to become pregnant. I did not make it to the end, although I tried again and I did become pregnant through IVF, and I have a 5-year-old son now. So I do have a success story, but like I said, there's so many different journeys and everybody's journey is unique. So that is my journey, and if you want more information on myself, you could go to my website, secretinfertility.com. I do blog about infertility, and I support many other people in the community, as well as connecting with many different professionals, like these two lovely professionals besides me, and I will like to introduce them now. We have Dr. Serena Chan. She is the director of the Division of Reproductive Medicine in the Department of Obstetrics and Gynecology at St. Barnabas Medical Center. She's the director of the Third-Party Reproduction and Ovum Donation at the Institute for Reproductive Medicine and Science at St. Barnabas. She's also a clinical associate professor in the Department of Obstetrics, Gynecology, and Women's Health at the University of Medicine and Dentistry of New Jersey. New Jersey Medical School in Newark, New Jersey. She practices reproductive medicine at the Institute for Reproductive Medicine and Science, IRMS, at St. Barnabas. That's a handful. You are
a lot of words.
A lot of words, but for a lovely lady, a lot of words and a lot of great expertise you're going to bring here today. And then we have Dr. Joe Cunningham. He holds a PhD in human embryology. He's a board-certified high-complexity clinical lab director in the disciplines of embryology and andrology. Dr. Cunningham has been the clinical laboratory director at Pacific Fertility Center in San Francisco for the past 12 years. So welcome, and I'd like to bring it over to you where you could give another little intro of what you do at St. Barnabas.
Well, I'm very happy to be here, first of all, at Fertility Planit. I'm very, very excited about the whole forum, the fact that we're live streaming, that people can come here in person, and that there's so much activity on social media that at IRMS we really are strong believers in patient education and information. And I was actually talking with Karen earlier about that New York Times op-ed piece, which I think a lot of us in the fertility world at first responded a little bit negatively because it seemed quite critical of the fertility field. But I really am very happy that that was in the New York Times and it brought more attention to Fertility Planit. And I think that the more dialogue we have about this whole process, the better, because there's a lot of statistics here involved. And it's very interesting, Fran, that you said you're unexplained infertility, because I find myself with so many of my patients saying that, you know, I don't know that I'm going to find you an answer, but for many patients, I do think we can get to the baby part, right. You know, but the journey is a difficult one because the per cycle, I think this is highlighted in the New York Times piece, the per cycle pregnancy rate is often less than 50%. I mean, we're approaching 50, 60% in better prognosis patients now, but the per cycle pregnancy rate is often less than 50%. But that leaves out a huge part of the picture in that, you know, when you try to have a baby on your own, a fertile couple tries to have a baby on their own, they have a per cycle pregnancy rate much less than 50%, around 20 to 25%. And some people get pregnant the first time they have sex, but a lot of people don't. They try for a few months, and fertility treatment has built into that kind of inefficiency of Mother Nature.
Right.
So it is a journey. It's often not like, here's your treatment, you do the treatment, you're done, you have a baby. It often is a journey, and I think was highlighted in the New York Times piece where they said people don't realize that there are a lot of failures.
Right.
But the other side of the coin, as Linda Giudice said from ASRM, the American Society for Reproductive Medicine, the big picture is that couples that proceed through that journey and persist and decide that they're going to go through with a lot of these new technologies and new treatments, most of them ultimately will find success. And a significant portion of people who don't find success, many of them, it was a choice. And that's what we're about here at Fertility Planit, hopefully, is that you can't have a choice if you're not informed.
Right.
Yeah,
and I
so
think
that's a huge part of it, is the information.
Right. And I think everybody's journey is so different that you can't compare my journey to somebody else's journey. And I think that's like the whole picture that people sometimes don't look at.
Yeah. Yeah.
So would you like to introduce yourself to Mr. Cunningham?
Sure. Thank you very much for that kind introduction, and thank you to Fertility Planit and to Oxygen for having us here today. I'm an embryologist, a working embryologist, and I'm one of those guys that works behind the scenes. And for many of you patients here in the audience and those of you streaming in, you don't often get to see what it is that we do with your sperm and your eggs and your embryos behind the scenes. So I'm hoping that we can dig into that a little bit today, and I can give you a little insight as to what it is that we do in the IVF lab. I've been an embryologist for 25 years now, and it's been a long and rewarding career. And I still am very excited to get up and come to work every day, because it's a rapidly evolving field, and even today we have lots of new technologies that we're able to take advantage of to help our patients achieve those pregnancies that they so desperately want. In the current climate here in the US, one of the things that we're really sort of striving to achieve is to send our patients home pregnant with a singleton pregnancy, because the safest outcome for patients and for the babies that we create is for everybody to be pregnant with one baby at a time. And now we're looking at a lot of technologies where we're really looking to do just a single embryo transfer. When I started as an embryologist 25 years ago, everybody had multiple embryos transferred to their uterus, and they were transferred quickly. We didn't keep the embryos very long in the lab. We saw that the eggs fertilized, we watched the embryos develop for a day or two, and then we put them back into the uterus. Now we're much more comfortable holding the embryos outside the body for longer periods of time so that we can make objective observations on how they're developing and how good we think they are. And the aim nowadays is to really transfer one embryo back to a patient's uterus. And the embryologist is a very important player in getting you to transfer that one embryo, because first of all, we have to be able to grow embryos successfully for you. And then we have to be able to pick out that one best embryo from a group of embryos that most patients create. And making that choice can be hard, but we have a lot of good technologies now that help us with that. And then finally, we have to be able to freeze the surplus embryos that you have. Because if we're going to try and convince you to transfer just one embryo, then we have to be able to give you the assurance that your other embryos will be here if you need them. So the embryologist is a very important player in fertility treatment nowadays, and I hope I can sort of, in the next hour or so, help you to get a little insight into our world, which most of you do not see as you come through fertility treatment.
Now, do you find that there's, just a question before we get to the discussion, do you find that there is a protocol now with single embryo transfers versus doing double embryo transfers? Are there new protocols out there with professionals, medical offices that only do single embryo?
I think we're moving
towards that.
We're moving towards that.
Okay.
But it's certainly not universal.
No, and in many countries, especially in Europe, and also in places like Australia and New Zealand, transferring just one embryo is mandated or highly encouraged, because in countries with socialized medicine, they just will not bear the burden of the twin and triplet and quadruplet pregnancies that are sometimes a result of IVF. In the US, we are not mandated or necessarily forced to do single embryo transfer, but it is the safest outcome for the patients and for their children. Our biggest issue in the IVF community right now is the high rate of multiple births that we have. The twin rate with IVF has been running at 30%, going back 5, 10, 15 years. And that number's not changing very much. And that's the biggest issue that we as professionals have to deal with right now.
I think one of the big issues is that when you see infertility patients that have been struggling for so long and have put so many of their resources into this whole process, they feel like they become attached to the idea of twins.
Right.
And that can often be a very difficult and emotional decision to convince them that, one embryo at a time is really what's best for them and for the baby.
Right.
So hopefully, we can get the word out there about that.
Right. Being a former patient, I know it was put as many back, because what if this one doesn't work? But then thinking about the whole picture, that one is safer.
More is not always better.
More is not always better.
Yeah.
Now, Dr. Chen, do you see that there's a breakthrough for improving the quality of eggs, like in the 90s for sperm with ICSI?
I think that ICSI has been a huge breakthrough in the 1990s for male infertility, and I don't think we have an analogous type of technology really for eggs. Perhaps the genetic testing will ultimately help us level the playing field for bad eggs or older eggs versus good eggs, the way ICSI has leveled the playing field for most all male factor infertility, so that even somebody with very, very poor sperm before ICSI maybe needed to use donor sperm in order to become a father, now can have their own genetic child using ICSI. And we don't have something like that really for eggs, but a lot of this genetic technology that I think we talked about this morning in this very room will, we saw that if you can get a genetically normal embryo, that perhaps you can eliminate some of this female age-related infertility factor. Right,
and is that, some doctors, they talk about age. Is that the only factor that most doctors look at now, or there's a broader?
There's multiple factors. And age is a frustrating one because we don't have a way to turn back the clock. But I think a lot of people, what I try to tell my patients is, obviously I can't turn back the clock, but we can improve your chances perhaps by doing things that are a little bit less glamorous than all this fancy lab work and the ICSI and the PGD and things like that. 50% of the population is overweight. If you look at the infertile population, the prevalence of overweight and obesity is even higher than in the general population, because there is a strong association between excess weight and infertility. Quitting smoking, eating better, getting exercise, all of those kinds of things are things that we can actually control, and we do have data showing that it can be associated with improvements in fertility. It's not necessarily going to be everything, but it is an opportunity to become healthier and plan for a healthier pregnancy and perhaps make yourself more fertile for these treatments.
Starting earlier.
Yeah.
We all like to say that we could do that. Dr. Cunningham, what are the indicators that the clinical team uses to determine day 3 or day 5 transfer?
This is a very interesting question because nowadays, with the technology that we have available, many people come into the clinic and they're asking for a day 5 transfer. And for those of you who don't know, doing a day 5 transfer just means that we've kept the embryos in the lab for 5 days, as opposed to shorter periods of time, like I talked about in the earlier discussion. So historically, we kept the embryos for short periods of time, and nowadays we tend to keep embryos for longer periods of time so that we can make more objective assessments on how the embryos are developing over time. Now, the one message that sort of is important in this question is that no embryo was ever made better by being kept in the lab for longer. Right? The lab is an artificial environment. No matter how beautiful we tell you that our labs are, and no matter what our technologies, the lab is an artificial environment. And as an embryologist, I believe that an embryo will always do better in the patient's uterus than it will do in the lab. So if we know early in the process which embryo we're going to transfer, then we put it back into the uterus early. So for example, a patient, say, that only has one embryo, there's no reason to keep that embryo in the lab for a long period of time. Put it back into the uterus. The uterus is the natural environment, the lab is an artificial environment. So get it back into the uterus as soon as possible. For patients who have many embryos and we have to make some sort of a selection, then it's appropriate to keep those embryos in the lab for a longer period of time, because as time passes, as the days go by, the embryos will sort themselves out, and you will see that some embryos are continuing to develop and some embryos are slowing down and perhaps even arresting in their development. So the longer you keep them, the more information you get, and also you see embryos reach the various stages. I have a graphic up here for people in the room, and we watch the embryos reach their various milestones or their various stages, and if we get to day 5 and we have a blastocyst, then we know that that embryo is appropriately developing for the length of time that it's being in culture, and we know that that's a good embryo to transfer. Many patients nowadays come in and they ask for a day 5 or a blastocyst stage transfer, even if they maybe only have one embryo, because they have this idea in their mind that doing a day 5 or blastocyst stage transfer gives them a better chance of becoming pregnant. And that's not strictly true, because the people who do day 5 transfers or blastocyst stage transfers tend to be the patients who have lots of embryos where we have to make a certain amount of embryo selection to find the good embryo in the group. So those patients as a group tend to be better patients than the patients who only have one embryo and where we do a day 3 transfer. So there's different, these are different patient populations. The people who end up doing a day 5 transfer, just by their nature, tend to have higher rates of success because they have more embryos to choose from. They respond to superovulation much better. And the patients who do a day 3 transfer tend not to have so many embryos and by their nature are perhaps not as successful. So patients who have low numbers of embryos shouldn't get hung up or shouldn't worry about doing a later stage embryo transfer. Just get those embryos back into the uterus early. They're back in their natural environment. We're giving them the best chance that they can have.
I'm so glad you're talking about this, because there are so many patients out there who feel like, I want to do the best thing, and I heard blast transfer is the best. And really what you're saying with your embryos is the same thing that physicians say with their patients. You have to individualize care. It depends on the situation.
Yeah, and the embryo that's in the lab, I mean, our lab in San Francisco is a beautiful lab, and I think it's a great environment for growing embryos. But I think there has to be some little bit of stress that the embryos are exposed to by being outside of the body. it's sort of like me. I mean, I stayed in a hotel room here in New York last night, and I never sleep quite as well in a hotel room as I sleep in my own bed. And I started thinking about the embryos. It's probably the same for those guys, right? It's comfortable, it's nice, it's beautiful, but it's not quite the same as being inside the body.
I like that analogy.
It's not home.
It's not quite home.
Exactly. Now, just a side note on this, do you both feel that patients are coming in a little more educated about the process and they're requesting day 5, or they're requesting certain things that obviously you can't really go by their request, but do you find patients are educating themselves more?
Yeah, no, I think it's good when people request those things, because it shows that at least they've been curious about things, they've been looking into things, and it's an opportunity for me to have a dialogue with them and to have an interaction with them and educate them about the process. And it's frustrating though, because as Joe knows, that ultimately we don't know until we know, you know, until he sees those embryos in the lab. He has to see, like, in a way, the embryos kind of tell you what they want. And we do have to, and it's hard because patients have to deal with so much uncertainty already, and we have to, but I think more information helps them when they understand this process. They see pictures like this, they understand what we're thinking, it helps them to, like, deal with that uncertainty.
Right, because they're coming in and they're saying, please transfer 2 embryos, day 5. You know, they're giving you instructions. So I was just curious of, like, do you feel that the patients are educating themselves more on?
I think most patients are open to, they come in with that, and most patients are not really set on that. It's really kind of a request for a dialogue, you know, to, like, tell me, like, include me in what's going on.
Right. Yeah. Interesting how things change. Dr. Chen, very interesting question. With male fertility, what should the male partner do to produce the best semen analysis on the day of egg retrieval?
Okay, so there are a lot of things that we don't have control over in life, and this is where the technology of the lab, I think, really we should take advantage of. And we can freeze sperm, and previously frozen sperm that has the same pregnancy rate in general most of the time as fresh sperm in the IVF lab. And I like my guys to have a little insurance policy and, you know, have a backup specimen, because God forbid, like, what if they get the flu that day, you know, and the timing is so critical. And you know, I've been there too many times where the husband's in the room and the wife is going, if he doesn't do this, I'm just gonna, you know, like, we've all been, you know, we've had those stories in those situations. So I think take advantage of the technology first of all, and you know, if you know even if you know you don't get nervous, you don't have complete control over everything that's going on, and you know there's a particular day, a particular time, just have that backup specimen frozen. You know, all the things that you know you're supposed to do for yourself, for your health: 7 hours of sleep at night, stress reduction, get rid of that gut, you know, eat healthy, don't be drinking like 10 beers every night, maybe take a vitamin, the guys, they really have a hard time with this, but go see the doctor, get a checkup, you know, and maybe listen to what they tell you about trying to be healthier. Those things are not very glamorous or high tech, but I think they do make a difference, probably much more than any kind of fancy supplements. There is some data out there about taking antioxidants, and you can pay for online fertility supplements and things like that. You can spend a lot of money on those kinds of things, but most of the data is really about being healthy. The whole abstinence thing, you know, honestly, Joe can speak to this also. In the IVF lab, they don't need a ton of sperm, and for many guys, the period of abstinence is not going to make or break you. So I tend to tell patients, you know, I don't want you obsessing about when was the last time you ejaculated, how often do you have to ejaculate. You can just drive yourself really
it's more
nutty.
Pressure for the man.
Exactly. So we try to be a little more chill about it and just, you know, say, be healthy, and, you know, those kinds of things.
And how many men actually go to the doctor?
Not very many. We're not very good at it, but you know, the advice of just looking after your general health is probably the best advice that we can give to a man. if the man is healthy, we're probably going to get a normal or a good sperm sample from him. In our clinic in
or their best sample.
Or their best sample,
right.
yeah. I mean, in our clinic in San Francisco, we're very minimally invasive, and we don't like to use the ICSI procedure where we inject the sperm into the egg unless we really have to. I mean, we do maybe about 35–40% of our cases where we inject the sperm, and the rest we do conventional insemination, where we put the sperm and eggs together, and we put on soft music, and we let them do their own thing. So, our biggest problem in the IVF lab is probably that we get a lot of guys that come in with very long abstinence periods, like they haven't ejaculated in 2 weeks because they think they can save up their sperm.
Yeah.
And you can't save up your sperm. Guys should ejaculate on a regular, fairly regular basis, and that's working the system, and it's clearing out the old sperm out of the system. And they shouldn't obsess about it. I mean, just do what feels natural, and on the day, give us your best sample, and if the worst comes to the worst, we can always inject the sperm into the eggs. But general health is the single most important piece of advice. A sperm takes almost 3 months to make, so you got to look after yourself over a long period of time. You can't decide that you're going to quit smoking the week before you do your IVF cycle, or you're going to give up beer, or lose a little bit of weight, or whatever it is. You got to look after yourself over a longer period of time.
And is that something you're finding that you're recommending to your patients more, like with the health and like the overall healthiness?
Absolutely, and I think these days people are listening more to the conversation about wellness, because I think that, that tends to be a trend nowadays.
It's the conversation out there.
Exactly, people are more interested in wellness, so I think there's more openness to that. So that's a good thing.
Right. I guess overall health for any type of situation is a good thing. Now, Dr. Cunningham, the slides that you were showing, what is the difference between the time-lapse imaging and the time-lapse analysis, and how will this be a game changer for the embryology laboratory?
Yeah, so one of the new technologies that is infiltrating IVF labs is the ability to watch the embryos all the time. So historically, as embryologists, we would get our embryos out of our incubator once a day or once every other day and take a quick look at them, and then get them back into the incubator as quickly as we could. So we take a snapshot 2, 3, 4, maybe 5 times throughout the life of the embryo, and then for an individual patient we would be making decisions on which embryos were best based on those snapshots that we took over a period of several days. But now we have access to a new technology called time-lapse imaging of embryos, and this is a new technology that allows us to use specialized cameras that go inside our incubators, and they take a very low light image of the embryo as often as every 5 minutes during the entire life of the embryo. And then over the 3 or 4 or 5 days that the embryo is in the lab, you get thousands of snapshots, and these are all then stitched together to make a video. And when this technology came out, we realized very quickly that many embryos are doing abnormal things, and I have a slide up here for those of you in the room to see that. And some of these abnormal things that embryos are doing, we cannot see by just looking at the embryos once a day or once every other day. You need time-lapse technology to see these things. And one example is where an egg fertilizes, and then that one big cell that's the egg, instead of dividing into 2 cells, it divides directly into 3 cells. And that's an abnormal event because the chromosomes that were present at the time of fertilization are now divided in 3 instead of being divided in 2, how they're supposed to be divided. And we find that these embryos implant at very low rates. And we see other types of abnormal cleavage where the embryo will divide normally during the first cell division, but then subsequently make a mistake. And when this happens, and it happens a lot, it happens in about 20% of embryos where they make a mistake in how they're supposed to divide. When this happens, these embryos are abnormal, and it seems like in the vast majority of cases they cannot give you a baby. It's very rare that the embryo can make a correction after that and actually give you a viable pregnancy. One of the problems we see with these early cleavages is that, these early abnormal cleavages, is that because these embryos kind of get a jump in the number of cells, instead of going from 1 to 2, they go from 1 to 3. Oftentimes when we come later on to look at the embryos and choose which embryos we're going to transfer, the embryo that divided abnormally has more cells than its sibling embryos, and embryologists can look at that and say, this embryo is ahead of the other guys, let's choose this one for transfer. So the prevalence of these embryos is about 20%, But when we look at embryos that get selected for transfer, it's actually closer to 30% because oftentimes these embryos are ahead. So now we have a technology, and I'm putting up another slide right here. Now we have a technology that allows us to see the embryos pretty much in real time all the time. And it's also evolving now to the point where we can do automated computer tracking of the embryos. And the computer can look at the embryo development, and you're seeing, for those of you in the room, you're seeing this on the screen right now. The computer can see when the embryos divide, the timing of when they divided, did they divide at an appropriate time or not, and did they divide from 1 to 3 cells, or did they divide from 1 to 2 as they're supposed to. And the computer can actually help the embryologist decide which embryos should be selected for transfer based on cell division parameters that predict this embryo has a high likelihood of succeeding or this embryo has a low likelihood of succeeding. And this technology is used in conjunction with what the embryologists normally do. So we still look at them, you still have a real person who's looking at them, but we're now using this technology where we can basically see the entire history of the embryo every 5 minutes over a period of several days, and we can make much more objective selections of embryos for transfer. And this is a very exciting technology for us as embryologists because it's a non-invasive technology. We're just watching the embryos. We're not actually going in and doing a biopsy or taking anything away from the embryo. It's very non-invasive. The light levels that these cameras use are extremely low, and we're able to see every mistake that an embryo makes now, so we can make much better decisions on which embryos to transfer. And this technology is really helping us to transfer a single embryo more of the time now, because we can be much more confident about the embryos that we're selecting.
And that's a trend that I think we've seen all day, is more and more information about the embryos. And the more information, I mean, right now, even with all this technology, we probably still only have the tip of the iceberg. But the more information we have about these embryos, the better we can figure out is this a baby or not?
Mm-hmm. And we don't have to transfer 2 or 3 or 4 embryos anymore.
Yeah, when you're more sure.
It's not necessary.
Yeah.
And will some of these time-lapse images help with like genetic screening? Like, will they like move forward with that, like with the time-lapse?
So the next sort of era in time-lapse screening, I think, is identifying now not only which embryos are developing normally, but perhaps which embryos are genetically normal as well. And screening embryos genetically for chromosome content is also a technology that's being widely used right now, and it's growing very rapidly. Because again, if we have that embryo that we're going to transfer and we know that it's chromosomally normal, again, that reduces our need to put back 2, 3, 4 embryos at one time. If we can put back a single normal embryo at embryo transfer time, there's no need to put back
the same pregnancy rate as we used to with 2 or 3 embryos.
Yeah. So the problem with genetic testing is that it's an invasive test. You have to go in and take away some cells from the embryo to actually find out if it's genetically normal or not. And maybe time-lapse and genetic testing will marry up in the near future, and a lot of the genetic abnormalities that are in embryos might be predictable based on cell division profiles of embryos.
I don't think we know that yet, but I'm sure people are working on that.
Right, and the time-lapsing, like with cryopreserved embryos, is there anything like that you could view those embryos as they thaw, and then the process, like is there anything with that time-lapsing for cryopreserved?
That would be interesting to look at, and I don't know that anybody's done that yet, though, right?
No, it's more likely that those particular embryos that are in the freezer were subject to time-lapse imaging before they were frozen, so that we already have the information for the embryos that are in the freezer. Because typically, again, if someone's coming in for a frozen embryo transfer, remember I said earlier that no embryo ever got better by being kept in the lab for longer? So typically with frozen embryo transfers, we thaw out an embryo and we transfer it within a couple of hours. Because there's no, I mean, if we're transferring that embryo, and we know we're transferring that embryo, there's no reason to keep it in the lab for long periods of time. So hopefully any time-lapse imaging would have been done on that embryo before it was frozen.
Right, like in my case with one frozen embryo transfer that I had, I got a call on the day of the transfer, and you never get a call from the doctor on the day of transfer, where the thawing process of the embryo, it did not make it. Right. So, I mean, is there anything that you could like say that I guess in the future they're going to be looking at like cryopreserved like embryos, like are the quality better if they're cryopreserved versus fresh, or everything's better fresh?
Not necessarily. I think that all of this goes to this idea of the more information we have, the better. And I don't think we have that information yet. but I could imagine that some of this, we could correlate some of this data with better freezing survival rates and those types of things. Because we do know, we have some information that certain quality embryos are associated with better survival rates, and that's how Joe and his colleagues make decisions about, well, we should freeze this embryo, but this embryo, there's no point in freezing this embryo. It will never survive. And I think the more information we get, the better we are going to be able to predict how well they freeze, how well they thaw, those kinds of things.
So they know that prior to freezing them, like that they might not be viable embryos.
Yes, the more we know,
freeze.
I think it'll help us in that prediction process. I think right now they're really pretty good at it, though. Like you're seeing, 85%, 90% survival rates a lot of times. So it's not perfect, though.
Right.
A lot of people do get that phone call, but it's pretty good, and the more information we get, hopefully the better it will get.
Right, of course. I mean, technology is, coming up with all different new innovations, and especially with reproductive health, we need the technology to kind of move forward with this. So I'm going to ask the audience if they have any questions for Dr. Chen or Dr. Cunningham. Yes. Do you have the microphone, Mary? Just bring it back to her. Thank you.
Hi, you had a slide earlier on that says that on day 6 it will be a hatching blastocyst and day 5 is a blastocyst. So what happens, if the embryo reaches a blastocyst on day 6? Does it mean that this embryo is not as viable? What are the implications?
That's a great question. Thank you very much. So we grow embryos for 5 or 6 days in the lab, and ideally what we like is for the embryo to reach the blastocyst stage on day 5. That's what we think is the normal timeline for embryo development. However, we do see a lot of embryos that develop a little more slowly in the incubator, and they do reach the blastocyst stage on day 6. Maybe that's as a result of being in the stressful environment of the lab, the artificial environment in the lab, right? The hotel room that's not quite your own bedroom. And maybe if those embryos were inside in the body, they would develop just fine. When we get embryos that get to the blastocyst stage on day 6, we're fairly confident that those embryos have the same potential to implant and give you a healthy pregnancy as embryos that reach the blastocyst stage on day 5. They're just a little slow, but we see implantation rates and pregnancy rates with day 6 embryos that are very similar to those with day 5 embryos. However, the day 6 embryos, most of the time we end up transferring those in a frozen embryo transfer cycle. We don't often find ourselves in the situation where we're transferring day 6 embryos in a fresh cycle, because for most patients, they have a group of embryos, and hopefully one or more embryos will have made it to the blastocyst stage on day 5, and then that embryo would be the one that would get transferred on day 5. If you don't have any embryos that get to the blastocyst stage on day 5, but they get there on day 6, we then start to worry that there might be a little asynchrony between the uterine receptivity and the development of the embryo. Maybe the embryo is a little slow and the uterus is a little further ahead, so we might miss the window of implantation. So oftentimes now we recommend that if you only get to the blastocyst stage on day 6, that those embryos get frozen, and then we bring you back in a natural or controlled cycle later on, and we put that embryo back in at the appropriate time in your cycle. We've also been doing a lot of genetic testing on embryos in the last year or two, and we're not seeing higher rates of abnormalities, genetic abnormalities in embryos that get to the blastocyst stage on day 6. So currently our plan for day 6 embryos is to transfer them in a frozen cycle, and we're seeing implantation and pregnancy rates that are just the same as for day 5 blastocysts.
Especially as the freezing technology improves more and more, we're getting better and better at freezing and thawing embryos. And so it's especially for a good quality embryo, it's less of a hit to be frozen and thawed, and it may that balance between the disadvantage of freezing versus putting the embryo back in a more normal environment has started to level out, so that now we're seeing a trend towards more and more, and I think we're going to see more of this, more and more frozen embryo transfers being done, because if you think about it, to make those embryos, we kind of have to change the uterine environment. Mm-hmm. It's impossible not to affect the uterine environment even a little bit when you're giving all those drugs and you're making somebody make more than one egg. You're automatically changing that uterine environment. And in the past, when we weren't so good at freezing, the disadvantage of the freezing was much greater than the disadvantage of that abnormal uterus. But now that we're starting to eliminate the disadvantage of the freezing, it may make more sense to transfer more and more of these embryos in a natural uterine environment. So freeze them first and put them back when everything has calmed down a little bit more. So I'm sure you guys have seen more and more of that. More clinics are doing a lot more of that.
Yeah, we've made huge advances in our ability to freeze embryos in the last 5 years. In our lab, we used to use a process called slow freezing, which essentially froze embryos very gradually over a 3-hour period of time. And in 2007, we moved to a new technology called vitrification, which you may have heard of. And vitrification is an ultra-rapid freezing method, and it works extremely well for embryos. We see, 98, 99% of embryos tolerate vitrification and come out the other side like they'd never been in the freezer at all. And the implantation rates that we see with embryos that have been vitrified are as good or better as with fresh embryos. So we now believe that putting an embryo in the freezer doesn't reduce its chances for getting you pregnant at all. Whereas, 5, 6, 10 years ago, freezing was kind of a last resort. We didn't like to have to freeze embryos. If we had good embryos, we would transfer a couple of them fresh, and the guys in the freezer were like, okay, maybe we have a chance. But now the embryos that are in the freezer, and if you have day 6 embryos, they'll probably end up going in the freezer. They have just as good a chance of getting you pregnant as if they were transferred fresh. So we're very comfortable and very confident with freezing technology right now.
And the freezing technology has really transformed the whole area of egg freezing. Joe's talking about the slow freezing versus the vitrification. And as I feel like, as far as the lab is concerned, in many ways I'm a layperson because I'm not actually, I'm sucking out the eggs and putting in the embryos, but I'm not handling all these gametes in the lab. And I did see the whole idea behind vitrification is it's this rapid progression through temperature. You drop the temperature so rapidly that the molecules they end up in this glass-like state so that you're not forming crystals and you're not damaging those delicate intracellular structures. And obviously, you can see how important that would be for embryos. For eggs, it's even more important because eggs have so much water in them. They're like basically a large bag of water, and you can see how crystals would be a huge issue. So this whole idea of the rapid vitrification and the advances in freezing technology now are also transforming egg freezing, which is a whole another conversation, for freezing for cancer patients, for social freezing, all of those kinds of things. And I think just a few years ago, we never would have been talking about these things. Mm-hmm. It's very exciting.
I'm sure.
Yeah, now we all have active egg freezing programs. That's part of what we do now, whereas 5 years ago, it wasn't so much a part of what we do.
Yeah.
You have another question?
The time-lapse imaging seems like a helpful tool to assess maybe risk for embryos in a non-invasive way that's not CGH, and maybe less expensive even. And my question is that it seemed like an earlier presenter mentioned a study that suggested that the best indicator of something similar to time-lapse was to look at the duration of compacting, and if it was more than 12 hours, that there might be a higher percentage of a problem, which would in some ways, sort of be contrary to what you're saying. So I was wondering if you could address that a little bit.
Sure. Thank you for your question. So time-lapse, it's a very versatile technology, and it allows us to do things like see when an embryo does something abnormal. Even though, we as embryologists are not looking at it all the time, we can review the video and we can see when something abnormal happens. The other side of that coin is that we can also look at all of the embryos that are growing in our lab and in every lab around the world that has time-lapse technology, and we can start to produce algorithms that tell us what is normal for the timings of the various cell divisions. So when I go from 1 to 2 cells, or 2 to 3, or 3 to 4, the windows in which those cleavages should happen are now pretty predictable. So there's lots of different measures, timing measures now, that we have gates, if you like, that embryos have to pass through within a certain time frame for us to consider that they're good embryos and that they're developing along a normal time track. And there are many of these gates, the company that are sponsoring our session here today, Oxygen, they have some timing parameters that are based on the very early cell divisions of the embryo, going from 1 to 2 cells, 2 to 3, and 3 to 4. But there are also many other published timings for embryo development that are perhaps also equally important. And such as you mentioned, the timing that it takes for compaction. When the embryo goes from having a bunch of loose cells to those cells sort of coming together and really gelling together and compacting to form what we call a morula. And all of those timings are very important, because if an embryo misses a timing going from one stage to the next, then that's perhaps telling us that this embryo is slowing down and maybe it's going to arrest in its development, or maybe there's something wrong with the embryo and it's not meeting its time points because it's genetically abnormal, or there's some other issue with the embryo, it's stressed out by the culture environment. So these timings are also very important to us. It's not just watching what the embryos are doing, but it's actually looking at the timings of development. And putting all of these things together, we think really allows us to really find the best embryo in a group. And we can go to patients and we can say, look, this particular embryo right here, it's a blastocyst on day 5. It's come through all of its timing windows at exactly the right time. It looks like a beautiful embryo. There's no reason for us to transfer 2 embryos today. We can just transfer this one embryo because we think this is the perfect embryo. It's behaving exactly as we would expect. So yes, timing is also important, as well as what the embryos are doing in culture.
But I guess what you're saying is some timings may not be quite as important, because some of these day 6 blastocysts that are a little bit slower to blastulate, they have different timing, and yet we're seeing that a lot of them have similar implantation potential.
Yeah, well, one of the things that we're seeing is that based on timings alone, we're seeing, for sure we're seeing one group of embryos that are meeting all of their milestones, are getting, going through the cell division processes at the right time, right? And those are what we consider sort of embryos with high implantation potential. And then we're seeing other embryos where the timings are way off. And in those embryos where the timings are really out, we rarely get a blastocyst. It's not very common to get that the embryo continues on and it makes a blastocyst anyway, even on day 6. But there's a group of embryos that are sort of in between the sort of highs and lows. And those are the embryos that, maybe they miss one timing gate, or maybe they're just a little bit out by, by 30 minutes or by an hour. And they're very close to what they're supposed to be, and they get there in the end. And if they do, then we still think that they have good chance of getting you pregnant. Maybe not as good as the other embryo that was right on the money all the way along. But based on what we're seeing, we're not throwing embryos away. I mean, even if an embryo misses its timing, but it eventually gets to the blastocyst stage, we will still freeze that embryo and keep it for use later. It just might not be the first embryo that we go to when we're trying to decide which one we're going to transfer.
Any other questions in the audience?
A lot of the innovations that you're talking about seem to be geared towards a higher percentage of success rates and improving those. Are there also innovations that are geared towards bringing down the costs of cycles?
I think that as more things, I think that when we listen to a lot of the talks this morning, a lot of the genetic testing is very exciting, very cutting edge, and this is the toughest part of what we do, is that I have these tools that can do really amazing things, and a lot of my patients, because of the cost, can't access those things. But that's the idea behind some of these platforms that are like the next gen platform, being able to analyze more and more things in a more automated way on a smaller and smaller chip. Hopefully we're moving towards lower and lower cost. And I don't know if you saw the Recombine presentation this morning, but what's very interesting to me is just that last year I would screen my patients for the standard American College of OBGYN cystic fibrosis, and then SMA and Fragile X, and each of those tests is almost $500 to $1,000 a piece. And now I have my patients spit in a little cup and they mail it to Recombine, and they get 170 genetic tests instead of 3 tests for a fraction of that cost. So I do think that as technology becomes more advanced and more automated, that hopefully the cost will come down. You know, I think these incubators are, it's definitely an initial cost for the lab, but I wonder if, does it help at all with the personnel and maybe take some of the burden off of them, or they're still, because it's more automated than just looking at every embryo individually.
Yeah, it's still more automated, but you still need the people there.
Yeah.
And in some cases, like with embryo culture, for example, we now have culture media that allow us to leave embryos undisturbed for very long periods of time. The embryologist doesn't have to be taking them out of the incubator to look at them or to refresh the media that they're growing in. So, you know, we may have little time savings there, but on the other side, we're doing a lot more genetic testing on embryos nowadays, and we're doing a lot more analysis to try to find that single embryo that we're going to transfer. So it's sort of evening out for us. We're not seeing any time savings right now. But like you say, the technologies are all evolving, and I think over time the cost of all of those will come down.
And I think one thing that we see from the insurance companies is they tend to look at a very low level and very short term. And I think some, you know, Alex Bisignano brought out some of this, as well as Dagan Wells in their talks, that there is a bigger picture there. If we're reducing miscarriage rates, and actually Mark Hughes brought this up as well, miscarriage rates, birth defect rates, and multiple birth rates. So you're paying an extra $5,000 for genetic testing, but you're transferring one embryo. If you have a singleton instead of twins, that's about an $80,000 savings just to get the twins out of the NICU. If you're saving yourself triplets, then that's $300,000 for a triplet pregnancy versus more like $40,000 for a singleton pregnancy. So I think we are getting a little bit more sophisticated at looking at some of these costs. It's not just the cost in the lab, it's the cost to the patient, the cost to the baby, the cost on labor and delivery, the cost in the NICU. It's kind of a more complicated equation, and I think when we think about the cost of these things, we have to take those things into account. And we've been working very hard to try to get the insurance companies to take a little bit more of a holistic view of the patient, as opposed to just saying, well, I don't want to pay for this test, but what are the benefits that you're going to get from this test? Maybe ultimately it will cost you less to do this particular test than not to do it. So I don't think there's any simple answer, but I think we do have to keep in mind that it's a big picture we have to look at.
You have a question, Mary Beth? Yes, question over there.
I just think you're overlooking the obvious here, which is that as IVF improves, it requires fewer cycles per patient to achieve a pregnancy and deliver a baby. So yes, it does decrease the cost to society as a whole. To an individual, maybe not yet, but we're working on it.
Any other questions from the audience? I actually have a question. With egg donors, if you're doing the time-lapse and the embryo development stages, are these techniques used for egg donors to see if there's anything with the embryos that could be determined?
Yeah, all of the technologies that we've talked about are equally applicable to individuals using egg donors as they are to individuals using their own eggs. People who do egg donor cycles are more likely to have embryos to freeze, for example, and you know, they can potentially also benefit from things like time-lapse or genetic screening of the embryos. We think that because egg donors are very young, we expect egg quality to be very high. So therefore, you know, it's not the first thing you think of to do genetic testing on the embryos, or maybe not even necessarily to do time-lapse imaging of the embryos, because you think that you start with good quality eggs, the embryos are going to be good quality as well. And perhaps those individuals are not the ones that are going to benefit most from these technologies, but they're still a benefit. With egg donor cycles, we see pregnancy and implantation rates somewhere in the region of 60 to 70%. I mean, that's for most IVF programs, that's what you're looking at, maybe a little more. But it's very hard to get even above that. I mean, maybe 70% is a ceiling for egg donor cycles. And you know, for the 30% of people who do an egg donor cycle who don't get pregnant, you then got to start wondering, well, was there something wrong with that embryo that we transferred, or maybe there's a uterine issue that hasn't been diagnosed. So to answer the embryo question, we can do things like time-lapse, or we can do things like genetic testing on the embryo. And we do see that about 25 or 30% of egg donor embryos are genetically abnormal. Even though these are young women, typically in their 20s, who donate the eggs, there's still a sort of a background or an underlying rate of genetic abnormalities even in those embryos. It's very low compared to most of the patients that we see, but it's there. And you know, if you're doing an egg donor cycle and you're still not getting pregnant, then we can utilize these technologies to try and perhaps up the odds that you will get pregnant. Or we can perhaps start wondering about the uterus and trying to figure out maybe that's where the problem is. It's not with the embryos.
Right. Anything else you guys want to add while we wrap it up, or?
I think that, again, I'm just happy to be here to get more information out there. I do think it's important. It's a complicated story, and it's not all positive. It's all not all negative, and I'm really happy people are here to like learn more.
Right, and like I said, being a patient, I was always the one behind the phone, like wondering, like, what's going on with my embryos, or what's going on with this. And this is very educational for those that are going through it, or going to venture out into the fertility world. There are so many different technologies that could help with possibly bringing home a healthy child. So I think it's great that you guys came here to share your expertise. And Oxygen, thank you for sponsoring this session.
Thank you.
And for TV, this is being live streamed, and videos on demand will be available. For further information on Dr. Chen and Dr. Cunningham, you could go to fertilityplanet.com. And thank you all for being here.
Thank you.